Hello, my name is Eric Borgerding, President and CEO of the Wisconsin Hospital Association, and I am pleased to be joined with the 2017 Physician Leader Representatives to the WHA Board of Directors, Dr. Andy Anderson and later Dr. Mark Thompson, in presenting the following video providing a brief overview of the new federal MACRA law that will be a significant change to the way physicians are reimbursed by Medicare.
Recognizing the benefits of working together rather than separately, Wisconsin's high degree of organizational alignment and integration between hospitals, clinics, and physicians has helped Wisconsin be a national leader in achieving shared goals to improve the quality and reduce the cost of healthcare in our communities.
Likewise, to help our members achieve those shared goals, WHA's mission to advocate, represent, and support our members has evolved beyond the walls of the hospital and increasingly includes a focus on supporting the delivery of care by physicians and clinics.
WHA has developed this short video for physicians to help provide a high-level overview of MACRA as your organization begins to make changes to succeed under this new Medicare physician payment model.
In April 2015, Congress enacted a law called the Medicare Access and CHIP Reauthorization Act, or MACRA, that will significantly change how Medicare pays for physician services. That law served as a compromise supported by the American Medical Association, American Hospital Association, WHA, and others to permanently fix and replace the flawed physician payment Sustainable Growth Rate Formula, or SGR formula, set in 1997 that required congressional action every year since 2003 to avoid physician Medicare payment cuts as high as 21%. MACRA replaces the SGR with a program intended to move Medicare payment toward paying for value and quality. While value-based payment models do create challenges, we know that Wisconsin is ahead of the curve when it comes to providing high-quality care. And we think that Wisconsin physicians and healthcare organizations are as well positioned as any state to succeed in a new value-based payment model. Since the enactment of MACRA, CMS has been on a fast timeline to implement the program. CMS first released proposed implementation rules in April 2016, finalized those rules in mid-October, and program changes begin to apply in 2017. With implementation deadlines quickly approaching, all healthcare organizations will be under pressure in late 2016 and early 2017 to quickly begin to implement changes to succeed under the new MACRA payment programs. MACRA will create two options for physicians and organizations to participate in the new payment program. One is the Merit-Based Incentive Program, or MIPS. CMS expects that the vast majority of physicians will participate in the MIPS option. MIPS will use performance measures to adjust a physician's Medicare payment. Generally, under MIPS, services provided in a higher quality, more efficient way will receive a higher payment, while services provided in a lower quality, less efficient way will receive a lower payment. The other payment program option under MACRA is Advanced Alternative Payment Models, or APMs. CMS expects fewer physicians to participate in the APM option initially. This is because for 2017, CMS is allowing just 7 alternative payment models to qualify under MACRA, and overall participation in those APMs to date is not widespread. The requirements for participating in an advanced APM that qualifies for MACRA incentive payment are many, including that the APM involve downside risk. Over time, CMS is hopeful that more organizations will participate in advanced APMs. Because CMS expects that the vast majority of physicians and organizations will participate in the MIPS option, we will provide a little more background on that option. MIPS actually combines 3 existing separate Medicare physician payment programs into one payment program: the EHR Meaningful Use Program, Physician Quality Report System, or PQRS, and Value Modifier Program all have similar goals but different performance measures. Each of those programs are now combined, modified, and better aligned under MIPS. Physician-specific results will also be publicly reported on CMS's Physician Compare website, created under the Affordable Care Act, also known as Obamacare. As mentioned earlier, a physician's or clinician's performance on MIPS measures will impact the payment for the physician's or clinician's services. Because MIPS payments are adjusted based on performance measures, MIPS payment adjustments will occur subsequent to the year services were provided. Thus, the first payment adjustments under MIPS will begin in 2019, but those payment adjustments will be based on one's performance measures for 2017. MIPS payment adjustments will be based on 4 different measure sets, each with their own weight. For 2017 performance, the quality component, which replaces PQRS, will comprise 60% of a physician's or clinician's payment adjustment in 2019. Advancing care information measures that replace EHR meaningful use make up the next 25%. Clinical practice improvement activities measures, which are new measures, will make up the 15% of the overall score. Lastly, a cost category calculated from Medicare claims makes up the last measure category. However, under CMS's final rule, cost category measures in 2017 will not impact payment. But by performance year 2019, the cost category measure will account for 30% of the total MIPS score, and quality category measures will be adjusted to 30% of the total MIPS score. Under the October final rule, participants in MIPS were also provided new options for participating in MIPS in 2017. Originally, CMS proposed requiring full participation in MIPS data submission in order to avoid a 4% payment penalty. However, the final rule allows MIPS participants 2 additional options for 2017 only. The test option will enable a MIPS participant to avoid a payment penalty by simply testing their data submission methods with just one measure. The partial option allows a MIPS participant to receive a neutral or small payment incentive by submitting 90 days of measurement data. Under the full participation option, MIPS participants are eligible to receive the full payment incentive pay, submitting at least 90 days of data for all 4 of the measure sets. After 2017, this additional flexibility is scheduled to be removed.
Hello, I'm Mark Thompson, family physician and Wisconsin Hospital Association board member. While Wisconsin physicians and healthcare organizations overall are well positioned to succeed in a new environment of quality and value-driven physician reimbursement under Medicare, WHA has been working to address reporting burden concerns and to provide more flexibility in how MACRA is implemented. In June, WHA was one organization invited to participate in a small regional meeting with the head of CMS, Andy Slavitt, to discuss MACRA rulemaking. During that meeting, WHA commented on the need for flexibility on the implementation timeline, modified measures that can better apply to physicians in rural areas, aligning incentives and measures between hospital and physicians to help drive improvement and reduce measurement burden, and maintaining flexibility for physicians in data collection and reporting to enable choices of measures that best support improvement work with their practices. We've been pleased to see new provisions in CMS's final rule issued in October that address many issues raised in that meeting with Administrator Slavitt.
As you and your organization begin your journey to implement this new era of value-based Medicare payment, WHA thanks you for your personal dedication and service to improve the lives of your patients.
Working together, physicians, hospitals, and healthcare systems have made Wisconsin a top 5 state for healthcare quality year in and year out.
And WHA will continue to do our part in the Capitol to help support you and your organization as you continue to provide the best and most efficient care possible to your patients, both in the hospital and the clinic and in your communities. Thank you.